Dear Professor Julie R. Brahmer, it is our great honor to invite you to participate in this interview. The interview topic is the highlights of IASLC 2020, North American Conference on Lung Cancer. Here are questions. The first question is, as a conference co-chair, could you please introduce the highlights of this conference?
Well, thank you very much for inviting me for this interview. So for the 2020 North American Conference in Lung Cancer, our goal of this meeting is really to update everyone, as well as also show some of the world some of the new data or updated data. And I think over the past 24 hours and then throughout the rest of today, we will get to see the exciting new data. And we also have amazing continuing medical education. We have experts from around the world talking about updates. And yesterday we talked about the updates on immunotherapy. We spent several hours discussing some of the new biomarkers, as well as discussing updates in studies such as Checkmate 9LA, as well as Checkmate 227, and then also looking at other drugs in mesothelioma, as well as trilaciclib, which is a CDK4 and 6 inhibitor. So just to hit the highlights, we know that Checkmate 9LA, combining nivolumab and ipilimumab with 2 cycles of chemotherapy, continuing on with nivolumab and ipilimumab, does improve survival over chemotherapy across the different subtypes of PD-L1 status. And so we continue to see that yesterday as presented by Dr. Carbone. This allows, at least in the US, opportunities to give nivolumab and ipilimumab even in patients with PD-L1 negative disease. I updated the Checkmate 227, which looked at a 3-year survival update of nivolumab and ipilimumab compared to chemotherapy. And this continues to show a survival advantage in both the PD-L1 positive disease, which that is the primary endpoint, and then also in descriptive analysis, it also showed continued improvement in survival in PD-L1 negative disease. Also, we did a landmark analysis at 6 months that those patients who responded within the first 6 months did extremely well and had prolonged duration of response that equated into improvements in survival as well across both PD-1 positive as well as PD-L1 negative disease. Dr. Wang from China also looked at another PD-1 antibody plus chemotherapy in squamous cell histology as well, but that did not show a survival advantage combining tislelizumab plus chemotherapy versus chemotherapy alone. There certainly was a trend towards positivity and quite interesting data. We also heard yesterday from Dr. Yap that also looked at pembrolizumab in mesothelioma. This was a single-arm study and showed consistent improvements in interesting responses, as well as prolonged survival in patients with mesothelioma. We also heard from Dr. Ferrato that looked at trilaciclib, which is a CD4/6 inhibitor that does seem to reduce the need of growth factors or red cell transfusions to manage chemotherapy-induced myelosuppression. Throughout this meeting, it's been our pleasure to have our patients be able to tell us about how these type of treatments have improved their outcomes and what sort of treatments and how their disease course and their journey through their cancer diagnosis and treatment has affected them. And so we've been proud to say that we have patient perspectives throughout this conference to be able to really help each oncologist frame how these treatments are affecting them and how these newer treatments may improve their outcome long term. Today, we're going to see other oral abstracts focusing on the driver mutations. We'll hear about pralasetinib, is a drug for RET fusion positive disease from the ARROW study. We'll also hear more about tepotinib, which is a MET exon 14 skipping mutation, tyrosine kinase inhibitor, and hear results from the VISION study. And then also we'll hear some real world data from folks here in the US about how immunotherapy does affect, as well as looking at CT screening. That's a wonderful part of being part of the IASLC. This is truly a multidisciplinary group. And so we have presentations by several different disciplines, including our radiology colleagues. We'll also talk about an update looking at different radiomic features, nodules through the NACLC study as well. We also interspersed also will be something called tobacco moments. And this is really looking at how tobacco cessation is performed in our clinics and recommendations on how best to do this, as well as particularly now, we also, with increasing telehealth throughout the world, how to do this type of counseling and recommendations to our patients. I think also just to highlight some of the talks of the initial intro ceremony where Dr. Bolani talked about our Lung Cancer Ambition Alliance. IASLC has aligned with several different companies as well as research projects. One is IASLC, which is looking at differences in lung cancer screening and looking at ways to improve the technology. We're also partnering with others to be able to give research grants, as well as support patients in need, as well as other projects that Dr. Bolani went over. So that certainly is a highlight. We also heard from Dr. Gerasimo, who has been on the front lines in Italy, taking care of patients with lung cancer affected by COVID. She initially spearheaded a database called TerraVault that has evolved to include several different investigators throughout the world, as well as now is supported by IASLC. And certainly we're encouraging folks to become involved and then put data in on any patients with thoracic malignancies that are diagnosed with COVID, so that we can look at various different aspects of their care as well as their outcomes. And so Dr. Gerasimo talked about that yesterday. So I highly encourage everyone. Within 48 hours, yesterday's talks will be available online to be able to look at that afterwards. And then right now it's starting the kickoff session about oligometastatic lung cancer is starting right now.
Well, thank you. Here's a question too. At the ESMO Virtual Congress 2020 last month, you reported updates, efficacy, and safety from Keynote 024 with 5 years follow-up. What do you think of this result? What does this mean for clinical practice?
Thank you very much. Certainly, we were excited to be able to present on behalf of my other co-authors the significant improvement in 5-year survival for patients with metastatic disease and high PD-L1. Finally, we can say in some patients, we can make this a chronic disease and potentially cure patients, showing that the 5-year overall survival was approximately 32%, which is a doubling in the trial of this. I think that that's the beauty of these type of trials, keeping track of these patients for this long of time and being able to show improvements. And I think, again, for patients with PD-L1 high disease, 50% or greater, this truly is groundbreaking research. And we'll see whether or not the chemotherapy plus PD-1 or PD-L1 inhibitors will result in this type of long-term overall survival. And hopefully in 5 years, we can present the 10-year overall survival.
Well, thank you. Here is question 3. The response rate immunotherapy was not satisfactory, and combination immunotherapy is a focus of current research. FDA has approved multiple immunotherapy combinations such as IO plus chemotherapy, IO plus IO, IO plus chemotherapy plus anti-angiogenic therapy. Which lung cancer patients do you think need combination immunotherapy? How to choose the combination therapy?
Well, I wish we had a perfect biomarker that could tell us what exactly to give our patients. And certainly right now, based on my practice, patients with indolent disease or small amount of disease, where I believe that single agent immunotherapy in those patients with PD-L1 high, I do feel comfortable giving single agent pembrolizumab or single agent PD-1 or PD-L1 therapy as approved in the US. I think for those patients who have rapidly progressive disease, adding chemotherapy to IO is appropriate. I think for me, adding bevacizumab plus IO plus chemotherapy, I don't use that much, but in the patient population with driver mutations, particularly EGFR mutations, this is the only regimen that has included those patients and then also showed a survival advantage. And this was not seen in the IO plus chemo versus chemotherapy arm in the IMpower 150 study. So that's what I use for those patients with driver mutations. For the nivolumab and ipilimumab or the checkmate 9LA, I'm still trying to figure out which patients I'm giving that different combinations to. I would love to have some data on this type of therapy in patients who had durvalumab in the stage 3 setting for maintenance. And when their disease progressed, it would be great to know if this type of regimen or these two types of regimens could be used. Again, I have used both of the regimens. And in the US, nivolumab and ipilimumab is only approved for patients with PD-L1 positive disease. And so despite the very interesting data on PD-L1 negative disease, the study just was not powered to be able to show a significant difference. So in patients with PD-L1 negative disease, really the 9LA study guides me there, giving nivolumab, ipilimumab plus chemotherapy. And so that's practically what I do. And truly it depends on what's available to you where you're at and practicing.
Well, thank you. And the question 4, at present, academic exchange activities are held in the form of offline and online in China. How about in the USA? What do you think of the impact of COVID-19 on academic exchange activities?
Yes, certainly. Certainly COVID-19 has made things more difficult. However, the virtual platforms, I think, has actually allowed more people to be involved and more data to be presented. Certainly it's easier for me to even hop on in the middle of the night to hear information that's coming from Europe or other places as well. So that part is great. I think we all miss bumping into each other in the hallways and talking randomly about exciting data that we're seeing. Some of us are more savvy at social media than others, and so you can see a rapid fire exchange on Twitter or other social media platforms. However, I think we all miss seeing each other in the poster sessions and being able to debate with each other about the significance of the data that we see, and then also meet some of the new up-and-coming investigators that are presenting their data. So I think we do miss that.
Well, thank you for your wonderful interpretation. We are done here today. Thank you.
Thank you very much.